Hello everybody, Dr. Ryan here. I'm a board certified specialist physician. Thank you so much for joining me even as we look at a clinical approach to a problem of jaundice. If you haven't yet subscribed to my channel, I strongly encourage you to smash that subscribe button, like and share. Thank you so much. Okay, you got a patient who has jaundice. The first certification point, right, is are we dealing with unconjugated hyperbilirubinemia, or is it a cholestatic hepatocellular obstructive picture, or is it a possibility of malignancy, right? So let's look at unconjugated hyperbilirubinemia. This essentially has to do with the problem of red cell breakdown. There's increased red cell breakdown and hemolysis for whatever reason, right? And that'll be evident. The patient may or may not have a splenomegaly and may or may not have a cholecystectomy. And an example of this is phagocytosis. Or are we dealing with Gilbert's syndrome, right? Which is a problem with the conjugation, right, of bilirubin to form glucuronides and therefore entering into the biliary system. Or are we dealing with the cholestatic picture? We have predominant elevation of a cholestatic enzyme to alkaline phosphatase, gamma-glutamate transferase, or is it predominantly hepatocellular with a rise in your transaminases, or is it obstructive? So here we're looking, if you've got a positive Murphy sign, then you're probably dealing with acute cholecystitis. If you've got diffuse hepatic tenderness, you must think about, especially a tender right upper quadrant. So tender right upper quadrant, you're thinking cholecystitis or hepatitis, and you must do a hepatitis screen, right? Hepatitis A, B, C, and also D and E, and also think about other viruses like Epstein-Barr and cytomegalovirus. Is it autoimmune hepatitis? Is it drug-induced hepatitis? Is it fatty liver disease, right? If you've got a patient who has obvious cirrhosis, you may have a non-tender right upper quadrant with or without hepatosplenomegaly, but often cirrhosis gives you a small shrunken liver with stigmata of portal hypertension, right? If dealing with a patient who has very deep jaundice with weight loss, you're thinking, maybe there's a malignancy afoot. Then you want to consider if there's knobbly hepatomegaly, it could be metastatic liver disease like CA colon. But if there's no hepatomegaly, but you do have a palpable but non-tender gallbladder, you're thinking about extrahepatic obstruction, which is where we invoke Courvoisier's law, which states that in the presence of a non-tender but palpable gallbladder, the obstruction is more or less likely to be stones, more likely to be carcinoma, especially the poster child for that is CA head of pancreas. So once again, guys, quick summary. If you've got a patient with jaundice who has mild jaundice, you're thinking, is the unconjugated hyperbilirubinemia, or is it a cholestatic hepatocellular obstructive picture? If it's unconjugated, you're thinking hemolysis or Gilbert's syndrome. If it's cholestatic hepatocellular obstructive, you're thinking if it's tender right upper quadrant, is it cholecystitis or hepatitis? If it's not, then it's cirrhosis with stigmata of chronic liver disease and portal hypertension with a small shrunken liver. If the patient has deep jaundice with history of weight loss, here we're dealing with a malignancy, which is if there's a nodular, nodular or knobbly HEPA, it's just metastatic. If there's no HEPA, and you got Courvoisier's law being positive, is it extrahepatic obstruction, usually from CA head of pancreas downstream. This is jaundice, yellowing of the mucosa, which you can see yellowing of the sclera. Now, how do you differentiate? I beg your pardon. For more information on technique of examining for jaundice, I encourage you to check out my video on approach to general examination. Now, from the history, what are very important questions to ask a patient who has jaundice? Let's cover the exclamation marks first. Have you had any fever, which may allude to cholangitis? Have you had a change in your appetite or weight, which is a harbinger for malignancy? Have you had any vomiting of blood or passage of dark stools? Right, which speaks to upper GI bleed, hematemesis, and melena stools on account of upper GI bleed from varices, which on the back of cirrhosis with portal hypertension. You know all those deals right there. So is your urine dark, or are your stools pale, speaking to obstructive jaundice? Do you have any skin itching, speaking to pruritus? Have you had any abdominal pain or change in your bowel habit? Then do you drink alcohol? How much, how long? And invoke the CAGE questionnaire. I'm sure we're all familiar with that, right? Do you have the need to cut down? Is it a eye opener in the morning? Do you feel excessively guilty about your alcohol intake, etc.? Have you ever used IV drugs? Now there we're thinking about hepatitis B and C, because those IV drug use is of course a risk factor for that. Go check out my video on drug addiction to cover that. Any tattoos is the same issue. Blood transfusion, same issue. Have you had any new medications recently, especially herbal medications? Have you had any recent contact with patients who have jaundice or liver problems? You're thinking about something contagious. Have you had any history of recently high-risk sexual behaviors, alluding to Hep B and C? Have you traveled overseas to areas when Hep A is endemic? Have you been immunized against hepatitis B? Have you had any history of inflammatory bowel disease? Because PSC shares an association with ulcerative colitis. Have you had any surgeries like pancreatitis or biliary? What is your occupation in terms of contact with hepatotoxins like aflatoxin? Is there any history of liver disease? Oh, a whole lot of things. Now, guys, I just want to outline the difference between hyperkeratinemia and jaundice. Hyperkeratinemia will cause yellowing of the skin, but not the mucosa. Right, but jaundice will cause yellowing of both. This is a patient with a normal palm, not acromegaly now, it looks big. And this is the normal size palm, but this is very, very, very yellow. That's hyperkeratinemia. It also keeps company with hypothyroidism, right? So I'm sorry that the font is a bit small here, but if you're assessing a patient who has jaundice, good to do a liver function, full blood count, urea electrolytes, and a coagulation screen. And the first question to ask, is there evidence of chronic liver disease? Right, you know the stories, we've covered this. Is there leukonoikia? Is there palmated? Is there axillary alopecia, testicular atrophy, together with the jaundice? Right, then you wanna consider causes of cirrhosis. If no, look at the pattern of liver enzymes. Are there normal liver enzymes, INR and albumin? If yes, then this is likely hemolysis or Gilbert syndrome. If no, is there evidence of obstructive jaundice or cholestasis? If yes, is that accompanied by fever, rigors, up quadrant pain, with the Murphy sign being positive? You're thinking about acute cholangitis. Right? Remember, Reynolds pentad and Charcot's triad and all those deals. And the answer is no for fever. Are there dilated bile ducts in ultrasound? If yes, then we're probably dealing with extrahepatic obstruction. If no, ask yourself, is the ALT above 500? You've got a raised INR and features of encephalopathy. The answer is yes, you're considering acute liver injury, being it viral or autoimmune or metabolic or ischemic or toxic. An example of metabolic is non-alcoholic fatty liver disease, NAFLD. If the answer is no, is there a palpable liver or suspected malignancy? Then you want to head over to an abdominal ultrasound or a CT abdomen for structural liver disease. If no, ask yourself, is there chronic alcohol excess or a recent sustained alcohol binge? If yes, consider alcoholic hepatitis. If no, is there a likely drug culprit? Yes, discontinue the offensive drug, especially now studying TB drugs, right? And consider drug hepatotoxicity. If no, consider viral or autoimmune hepatitis, hepatocellular carcinoma, metabolic liver disease, targeted investigation in suspected causes, otherwise full liver screen and abdominal ultrasound. Here are screening investigations in jaundice or in a patient in whom we suspect liver disease. So they stratified into serology, metabolic, autoimmune, and others. Serology is obviously your hepatitis B surface antigen, your Hep C antibodies, which are IgM against Hep B core, hepatitis A virus, hepatitis E virus, CMV, EBV if acute. Metabolic, you're thinking about ferritin, alpha-1 antitrypsin, ceruloplasmin. Autoimmune, you're thinking your antimitochondrial antibody, which speaks to primary biliary cholangitis, right? Anti-smooth muscle, and anti-LKM, which speaks to autoimmune hepatitis, as well as ANA, which is anti-nuclear factor, and do your serum immunoglobulins. Others is abdominal ultrasound, alpha-fetoprotein, paracetamol, and toxicology. Remember that all patients with cirrhosis must have annual ultrasound, or even 6-monthly ultrasound, and alpha-fetoprotein to screen for malignancy, which is hepatocellular carcinoma. Okay, my friends, in the book of Luke chapter 9, verse 23, the Lord Jesus said, if anyone would come after me, he must deny himself, take up his cross, and follow him, or follow me. Right? Following Christ means that we must crucify the flesh man, deny ourselves, and follow him. And how do we follow Christ? By looking at his example as revealed to us in the Gospels. And in every situation, comparing our reaction to how Jesus reacted. To look at his attitude to money, to look at his attitude to lust, to look at his attitude to anger, and to things that we are commonly tempted with. And to look at him, because Jesus Christ is our forerunner, he is our dictionary, he is our example to follow. I pray that upon our lives. These are my references. Have a lovely day. I'll see you soon with another helpful video in this series. God bless.